All right. If anyone who is hovering near the robot should come back. We've like sabotaged ourselves by putting the robot out there because there's like 30 people hovering around the robot. It's really not that cool, everybody. It's really boring. Come back. Yeah. Um, okay. We have some people still logged in for the afternoon session, hopefully. Okay. So I wanted to just give a heads up for those of you who do not have tickets to our Cruising for the Cause event tonight at O'Malley on the Green. It's going to take place at 7. It's going to be a band. There's going to be celebrations, community. It's really fun. We always have a music event during our Arts of Healing weekend. And this year, one of our new board members spearheaded this, and we're really excited to celebrate it together. We got lost. We're good. We're not screen sharing. Tessa, should we get moving? Yes. Okay. Okay, so for the second half of our Saturday, I'm going to invite back up to the podium Dr. Charlotte Marcus, who's going to be speaking to us about some really important changes that have happened in terms of how we look at endometrial cancer. Endometrial cancer, Dr. Harshti alluded to this earlier, has the way we're thinking about it has seriously changed in the recent years, and now we classify it differently, and those classifications have important treatment impacts that we're all starting to fold into our clinical practice. So I asked Dr. Marcus to speak on this important topic. Thank you.
Hey, so interestingly, the area where we use the robot the most is uterine cancer. So maybe we can get all the robot fans to come in. Yeah. So I'm basically going to talk about the rationale behind changing the endometrial cancer staging at this point. I'll go through just sort of the highlights of each of the different stages and talk about the clinical applications that are in use thus far. So, FIGO staging has been around since the 1940s. And when we think about the goals of staging, the primary purpose is to aid clinicians in planning treatment, to indicate prognosis, to facilitate information exchange globally, and to be user-friendly for all different clinical environments, and it has to adapt to scientific development. So as we look at endometrial cancer, initially in the 1970s, it was all clinical staging, and then it became more based on surgery and what the pathology looked like. It was changed in 2009, and then this is the most recent change. The sort of center that guides pathology has really transitioned from anatomic to biomarker and molecular data over the last few years. So, for example, in breast cancer, you get a score that determines whether you should undergo adjuvant treatment or not. Prostate cancer, other cancers where they are really relying on molecular data. In 2013, the Cancer Center Genome Atlas released important data that allowed us to classify endometrial cancer into 4 categories, and that's what was incorporated into the 2023 staging. You'll see that. In general, there's a move towards risk stratification. There's been WHO updates in 2020 about endometrial cancer. So there were all these changes happening, as well as clinical data that really drove all of this. So in terms of the highlights, so the first thing is that endometrial cancer used to have 3 grades, grade 1, 2, 3. And this is moving away from that, such that now there's a non-aggressive type, so endometrioid grade 1 or 2, which is primarily about 70% of all cancers, and then the aggressive types. So the former grade 3 is now just classified with the aggressive types, and it also includes serous carcinomas and other histologies. The other major change is really trying to quantify the extent of both the lymphovascular space invasion, the LVSI, as well as the volume of disease in the lymph nodes. So we don't just want to know that the lymph nodes are positive. We want to know, whether there's micrometastasis or macrometastasis, and then integration of molecular markers. So for stage 1, these are all going to be our non-aggressive endometrial cancers. They are going to have the absence of LVSI, or you could have an aggressive histologic type that just has no myometrial invasion. So the new thing in stage 1 for a lot of us was something we used to call synchronous ovarian and endometrial cancer. So these were your patients that are your patients that have an low-grade endometrioid cancer, and it just involves one ovary. There's no myometrial invasion, there's no LVSI, and so the overall prognosis for these patients is excellent. And so they're now classified as stage 1A disease, where in the past, some of these patients may have been classified as stage 3 and gotten chemotherapy. So that is a big change. Stage 2 is cases that are non-aggressive but have a lot of LVSI, or your aggressive subtypes that are not confined to the uterine lining or a polyp. And this is probably the stage that's going to expand the most. I'll show you later on how these changes will impact how patients are staged. But this is one of the stages that are going to expand the most. And then the molecular profiling is really most important for stages 1 and 2, not so much for the advanced stages. There's stage 3, they have differentiated a stage for ovarian involvement versus serosal involvement, because we know those patients have different outcomes. And then they've divided pelvic carcinomatosis, so whether there's tumor studding in the pelvis, from upper abdominal disease. So for example, the thought behind that is if you have upper abdominal disease, that's a higher stage, and you might choose chemotherapy in that patient. It's different from someone who has pelvic confined disease. And then this is something we've all been doing in practice in terms of looking at micrometastasis or macrometastasis or isolated tumor cells. So these are things that we are familiar with in practice, but will now be incorporated as part of the staging, which is helpful. And then stage 4, the biggest change is they have divided those patients who may have liver involvement or organ involvement from those who just have carcinomatosis, because that is a real difference in prognosis. So the quantification of LVSI is really one of the most controversial areas of this new staging system. As I was reading about how this all went down, or who was in the room, if you're familiar with Hamilton, right? But who was in the room when these decisions were made, and it looked like there was one pathologist. And so the task of classifying whether the lymphovascular space invasion is focal or extensive is really difficult. And one author was arguing that if there had been more pathologists in the room, we may not be here, okay, because it hasn't been clearly laid out how to make this distinction. So for example, when you're looking at LVSI, are you looking at it on one slide? Are you looking at it on 3 slides? You know, how do you gather this information and what are the criteria? The research is still out. In addition, there can be some mimics of LVSI that decrease the reproducibility. So sometimes, you know, when all the time when we're doing this surgery, we put in a uterine manipulator. And as we're moving the uterus around, you can get displacements of tumor fragments that can look like LVSI. Or when we process a slide, there can be retraction of the stroma, and that can also mimic LVSI. Or you can have inflammatory cells in the endothelial spaces that mimic LVSI. So this is just to say that, you know, there's a question about reproducibility within institutions, across institutions, that is of some concern. Nevertheless, we know that quantification of LVSI is very important. There is a trial that was done by Bossi et al. In 2015, where they took all the data from PORTEC 1 and 2, which are major trials that look at how we treat patients with radiation after surgery. And they were able to classify those patients into those who had substantial, mild, or no LVSI. And on the vertical axis, that's the risk of distant metastasis, which is much higher if there is substantial LVSI versus no LVSI. In addition, when LVSI is present, the risk of, it's a huge risk factor in terms of overall survival, probably one of the biggest risk factors in term versus like myometrial invasion or all the other things that we talk about. So it's one of the single biggest predictors of recurrence for endometrial cancer. So that is what drove the inclusion of LVSI into the new staging system. In terms of the molecular markers, so the chart is just to remind us of the TCGA Cancer Genome Atlas classifications of endometrial cancer. And this integration of molecular markers is encouraged, but not required for the new FIGO staging. So they simplified the TCGA classifications because we don't speak in terms like ultra mutated or hypermutated. Those are a little bit more challenging to speak in those terms, but we speak in terms of things that are poly. So poly mutations or MMR mutations, P53 mutations, and then there's sort of this last basket of people, which is no specific molecular profile. And if you look at the table on the bottom, so if we take women with endometrial cancer, the prevalence of poly mutations is about 8%. So it's fairly low. P53 mutations is about 21%. MMR deleted is about 32%. And then there's nearly 40% of patients who will have no specific molecular profile. How does this translate into outcomes? So this is the same classification as the TCGA data that I just showed you before. And across multiple studies, you'll see that patients who have P53 mutations, always outlined in the red, have poorer outcomes than those who have POLE mutations, which is outlined in blue. This has been confirmed basically in every trial since the TCGA data was released. So remember that I said that the molecular markers are optional. And really, if we use them for stages 1 and 2, it can change how we treat patients. So you may see a stage that is now going to look like the lettering at the top. Stage 1A little m, which means molecular POLE mutant. And that means that regardless of the LVSI or histologic type, that patient has had POLE testing, and that's going to be their actual stage. That's going to be the driver. Similarly, with P53 mutations, you may see that stage 2C little m P53 abnormal is how it should be indicated. And again, that's based regardless of any other pathologic factors. For all other situations, stage 3 and above, it's still recommended to do the molecular testing to describe it, but it will not be part of the staging. You won't see it written that way. You may see it indicated as below, like stage 3C2 molecular P53 abnormal, or stage 1B molecular MMR deleted. So there's one study that was done by ESGO to validate this information. So what they did was they went back and they had about 500 patients that were eligible for analysis to see what the impact of the molecular classification and all of this would be. So they took these 513 patients, about 90% of them had the molecular classifications available. And they looked at how many patients would have their stage changed between 2009 and 2023 staging. And that was about nearly 30%. So nearly 30% of patients would be classified differently based on this new staging. This was most prominent in early stage patients who were upstaged. So for example, if you had a uterine serous cancer before, but it was a stage 1, you would now be a stage 2C. P53 abnormalities were other reason patients were upstaged. On the other hand, if you were, stage 3, but you had a POLE mutation, then you'd now be stage 1. So these kinds of changes happened in about 30% of their sample. But in general, they found that the 2023 staging was more predictive of progression-free survival and overall survival than our 2009 staging system. So this is a graphical depiction of that. So what you're looking at is the 2009 staging on the left, and then the 2023 staging on the right. And so if you see a line that's just going straight across, really nothing has changed. But if you look down on the left-hand side, those were patients with stage 1B disease in our former classification. And now they're all over the place, right? So some of them now, because of a POLE mutation, they're now, stage 1. There are some who are now stage 4. And really the biggest impact of this, again, is the histology as well as the mutation. So this is going to be challenging for us in terms of comparing cohorts across trials. In terms of the advanced stages, there were not so many changes there, so many stage shifts, they're called. But we're already doing this. We're already doing a lot of incorporating molecular testing into how we treat our patients with endometrial cancer. So, for example, in the PORTEC-3 trial, which compared radiation treatment versus chemoradiation in women with uterine cancer, they were able to select out the women who had P53 abnormalities. And you can see that women who had a P53 abnormality had a much better progression-free survival when they were given chemotherapy and radiation as opposed to just radiation alone. So that is one way we can use this molecular data. In addition, the Ruby trial that was discussed earlier was a major endometrial cancer trial that looked at chemotherapy and carboplatin and paclitaxel versus adding dostarlimab. And just you can appreciate the differences in the lines. So on the left-hand side was the overall study population. And the top line is the patients who were given dostarlimab in addition to carboplatin and paclitaxel. The red line only got chemotherapy. And then they subsegmented this patients who had deleted MMR or mismatch repair genes, and you can see there's a greater separation. So those women benefited more from dostarlimab because of their mismatch repair deficiency than the overall study population. Similarly, another trial looked at PORTEC-1 and 2 and looked at does molecular classification really affect radiation treatment? And again, in P53 patients who have P53 mutations, they certainly do better with external beam radiotherapy versus vaginal brachytherapy. Whereas this other cluster of nonspecific molecular profile, there was no difference whether you treated them with vaginal brachytherapy or external beam radiotherapy. So this has really been revolutionary, along with other revolutionary things that are going on in endometrial cancer. What are some controversies and future directions? I can tell you, surveilling my colleagues, there are few people who have implemented this fully because of the issues I'm going to mention. It's complex and it's different than our prior staging system, but we've been here before, so this too shall pass and we will get used to it. But there will be some lag time in adoption and translation. I showed you there was about a third, 30% of the patients would now be reclassified. And so when you're looking at trials that we'll do in the future versus trials we've done in the past and trying to build on our scientific data, it's really difficult because the patients are not in the same stage. So you can't do cross-trial comparisons. Inter-observer reliability. So when I was discussing, how pathologists at one institution may classify the lymphovascular space invasion versus someone across the country. When we look at the grade 3 endometrioid cancers will now be separately classified as aggressive, but not all grade 3 endometrial cancers are the same. So for example, if you have a grade 3 endometrioid cancer with a POLE mutation, that's a really good prognostic factor, but you would still be classified as a stage 2 instead of a stage 1. So there are different flavors here, and the new staging does not really address that. And then we don't know what to do if the people in the middle, because we know if you have a POLE mutation, you have a favorable prognosis. If you have a P53 mutation, that's a little bit less, but nearly 60% of the patients will either be MMR deleted or no specific molecular profile. And there's no, guidance yet on what to do with those patients. And then what if the testing is not available at all? So forget even resource poor settings. I can tell you at a, major academic institution, we still don't have a way to do POLI testing in our hospital. So for example, if you get a diagnosis of endometrial cancer, and we've decided how we're going to treat you, your testing has to get sent out to get the POLI testing. That may not arrive for 2 to 3 weeks. And then all of a sudden, the stage that you thought you were is no longer the stage that you are. Okay. And so that's going to be something that we have to navigate. We are all kind of uncomfortable sitting on making clinical decisions for 2 to 3 weeks until all the information is in, but that's a possibility unless we can figure out a means to do the testing faster. I'm sure there's someone smart working on that. And then global acceptance and translation. So these are US-based things. It's fairly easy in resource intensive studies to get, testing for P53 abnormality, for example. But in places where this is not available, then you lose the ability to communicate, right, and do trials across the globe if we're not all using the same language, which is really one of the major things that you want for a staging system. In general, patients are very accepting of molecular testing and more information so that we can be more precise in care. But, it remains to be seen whether people are willing to wait the extra time. So there's a lag time, and then there's sort of differences in the POLI mutations, which I won't go into, but not all POLI is made the same. So hopefully there will be some prospective studies, I'm sure, such as the Ruby trial or PORTEC or any of the major trials that incorporate molecular data into management algorithms so that we can gain more information here. I was just talking, I don't know if any of the docs can speak to whether they are using the new staging yet. We're trying. Yes. You're making her. We can't get POLI testing in your hospital. So how do you get it done? Okay. Okay. So
and it's based on digesting everything I say myself. Then the next step is NPS, which gives me a 6 weeks time to get those results back, and then potentially I will not give the break there. If it's only but in frequency, I mean, I think you've probably seen this too. In the one where they looked at it, it was 5% or whatever, but in the real world, it's like 1%. So it's pretty unusual for that to, I think that those tumors are just a lot less common than we thought that they were based on TCGA.
Yeah.
All right.
Okay. All right. Well, thank you.